Welcome to the Deep Dive. Today we're tackling something really significant: oppositional defiant disorder, ODD, and conduct disorder, CD. These are actually among the most common reasons kids end up in clinics, and the impact is just huge: personal struggles, school problems, legal issues, not to mention the cost to society.
Yeah.
So our mission today is to really dig into the diagnosis, the causes, and the treatments, drawing straight from a cornerstone text, Kaplan and Sadock's comprehensive textbook of psychiatry.
Right, and it's a great source because ODD and CD, they sit within this broader category in the DSM: disruptive, impulse control, and conduct disorders. They all involve self-control problems, that's the link. But what makes ODD and CD stand out is how that lack of control plays out. With ODD, it's mostly conflict with authority figures, parents, teachers, defiance, arguing.
Okay.
CD, though, that's more about actions that violate societal rules or, importantly, the rights of other people. And a really critical point the text makes up front is context. You have to consider age, gender, culture. What looks like defiance might be typical for a toddler, but it's a very different story in an older child.
Absolutely. Okay, so let's unpack ODD first. The textbook lays out 3 core symptom clusters. What are these dimensions exactly? How do they figure these out?
Yeah, they came from research, specifically factor analysis, grouping symptoms that tend to hang together. The first is angry, irritable mood. Think frequent temper tantrums. The child is easily annoyed, often seems angry or resentful.
Right.
The second is argumentative, defiant behavior. This is that classic stubbornness, refusing to comply with requests from adults, deliberately annoying people, blaming others for their own mistakes, that kind of thing.
Like defiance?
Exactly. And the third cluster is vindictiveness. This is about being spiteful, wanting revenge. And for the diagnosis, this has to have happened at least twice in the last 6 months. It sort of ups the ante in terms of severity.
That vindictiveness piece really does sound serious. So the formal diagnosis needs what? 4 symptoms out of 8 possibilities? Over 6 months?
That's right, 4 or more symptoms. And crucially, these behaviors need to show up with people other than just siblings.
Okay, that's an important distinction. Why filter out sibling squabbles?
Well, sibling conflict can be pretty intense and honestly pretty normal, right? The criteria aim to capture a pattern of difficult behavior that affects relationships more broadly with parents, teachers, peers. It shows the problem isn't just specific to that one, often very charged family relationship.
Makes sense.
And frequency is key, too, to separate it from just, bad weeks or typical boundary pushing. For kids under 5, the behaviors need to happen most days of the week.
Most days? Wow.
Yeah. For kids 5 and older, it's less frequent but still consistent at least once a week. It's about that persistence and pervasiveness.
Okay. Now, something else that often comes up is the overlap with disruptive mood dysregulation disorder, DMDD. They both involve anger and irritability. How do clinicians tell them apart?
That is a really common question. And yeah, the overlap is significant. Many kids might technically meet criteria for both. The key difference is the mood between outbursts.
Okay.
With ODD, you have these episodes of anger, irritability, defiance. With DMDD, the negative mood, the anger and irritability is severe and it's persistent. It's there most of the day, nearly every day, even when the child isn't having a major tantrum.
So it's like a constant state.
Exactly, a pervasive negative baseline. ODD is more episodic in that sense. And because DMDD represents this more severe chronic mood issue, if a child meets criteria for both, the diagnosis given is DMDD.
Got it. That clarifies things. So we know what ODD looks like. What about the why? The book calls ODD a transactional disorder. What does that mean in practice?
That's really the central idea for understanding how it develops. Transactional means it emerges from this ongoing back and forth interaction between the child's own characteristics, like their temperament, and their environment, particularly parenting responses.
So not just one cause.
Right. It's not just the child or just the parenting, it's the interplay. A difficult child temperament might elicit harsher or inconsistent parenting, which then fuels more defiance from the child, which leads to more parental frustration, and on and on. It's a cycle.
And the book highlights Gerald Patterson's coercion theory as a major explanation for this cycle. It sounds like it uses basic learning principles.
It does, specifically negative reinforcement. It's a very influential theory. Patterson basically described how this cycle gets locked in.
How does that work? Can you walk us through it?
Sure. So imagine a child who's naturally pretty emotionally reactive, maybe has poor self-control. A parent makes a reasonable request, time to clean up your toys. The child dislikes the request and throws a huge tantrum, screaming, maybe hitting. The parent, maybe stressed or tired, just wants the noise to stop, so they give in. They might say, okay, okay, fine, or even clean up the toys themselves.
Right, just to get some peace.
Exactly. And in that moment, the child's tantrum worked. It made the unpleasant demand go away.
Okay.
That's negative reinforcement. The removal of something unpleasant reinforces the behavior that caused the removal. The child learns, hey, acting like this gets me out of things I don't want to do.
And that pattern just repeats and gets stronger.
Precisely. Over time, the child learns that coercive, aversive behavior is an effective way to control social situations. And the parent, by giving in, also gets reinforced. They get temporary relief from the tantrum, so the cycle sustains itself.
That's powerful. Are there other factors mentioned that contribute besides this cycle?
Oh, absolutely. The coercion cycle doesn't happen in a vacuum. There's evidence for genetic vulnerability. These kinds of oppositional traits do tend to run in families. And major sociologic factors play a role. Poverty, community violence, parental mental health issues like depression, high family conflict. All these stressors can make consistent, positive parenting much harder, feeding into that coercive loop. Harsh or inconsistent discipline is also strongly linked.
Okay, so it's a complex mix. Let's shift gears now to conduct disorder, CD. This is generally seen as more severe, right? How is it defined?
It is, yes. CD is defined by a repetitive and persistent pattern of behavior where the basic rights of others or major age-appropriate societal norms or rules are violated. It's a step beyond defiance into actively harmful actions.
And the diagnosis requires seeing a certain number of these behaviors.
Yes, the criteria list 15 specific behaviors. To get the diagnosis, the individual needs to have shown at least 3 of these in the past 12 months, with at least 1 present in the past 6 months. 15
is a lot to track. The book groups them into 4 categories, which helps. What are those?
That grouping is really useful. The first is aggression to people and animals. This is serious stuff. Bullying, initiating physical fights, using a weapon, physical cruelty to people or animals, stealing while confronting someone, like mugging, even forcing sexual activity.
Wow, okay. Very serious.
Definitely. The second category is destruction of property. This includes things like deliberate fire setting with intent to cause damage or intentionally destroying other people's property in other ways.
Third.
Deceitfulness or theft. This covers breaking into someone's house, building, or car, frequently lying to get things or avoid obligations, conning others, and stealing items without confrontation like shoplifting or forgery.
That last one.
A fourth is serious violations of rules. This includes things like staying out late at night despite parental rules, starting before age 13, running away from home overnight at least twice, or frequent truancy from school, also starting before age 13.
Got it. And the book mentions severity levels. Mild, moderate, severe.
Right. Severity isn't just about how many symptoms you have, though that plays a part. It's more about the amount of harm caused. Severe CD might involve behaviors like forced sex, physical cruelty, use of a weapon, breaking and entering things with significant impact on victims.
Now, this is where, as you said, it gets really interesting. The textbook stresses that CD isn't just one thing. There are important subtypes based on age of onset and this key specifier about emotions. Let's start with the age.
Yes, the age of onset is a critical distinction. There's the childhood onset type, where at least one symptom shows up before age 10. This subtype is generally associated with more physical aggression, a worse long-term prognosis, often leading to antisocial personality disorder in adulthood, and more likely to have co-occurring issues like ADHD or neurocognitive problems like lower verbal IQ.
Okay, so early start means potentially more ingrained problems. What about the other type?
That's the adolescent onset type. Here, there are no signs of CD before age 10. These behaviors emerge during adolescence. While still serious, this type is less likely to involve extreme aggression and less likely to persist into adult antisocial behavior. It's often linked more strongly to peer influence, hanging out with a deviant peer group, and can sometimes be seen as sort of an extreme form of teenage rebellion.
Right. And then there's this other layer, the limited prosocial emotion specifier, LPE. This sounds like it identifies a particularly concerning subgroup.
It absolutely does. This specifier, sometimes referred to by the traits themselves, callous unemotional or CU traits, flags a subgroup of kids with CD who show a distinct emotional style. It points to a more severe, stable, and frankly, much harder to treat form of the disorder.
What specific traits define LPE?
To get the LPE specifier, the child has to consistently show at least 2 of the following 4 traits over at least 12 months, and across different relationships and settings. First, lack of remorse or guilt. They just don't feel bad or guilty after doing something wrong, beyond maybe getting caught. Second, callous lack of empathy. They're cold, uncaring, disregard the feelings of others. Third, unconcerned about performance. They don't put effort into important activities like school, and they tend to blame others for their poor performance.
Mm-hmm.
And fourth, shallow or deficient affect. Their emotional expressions often seem shallow, insincere, or used just to manipulate others, like turning emotions on and off like a tap.
That combination sounds chilling, and the link to biology here is fascinating. The text says kids with LPE and kids without LPE show opposite physiological patterns.
Yes, this is a crucial finding. It suggests fundamentally different mechanisms underlying the aggression. Kids with CD and LPE tend to show reduced physiological arousal. They're sort of underreactive emotionally. They don't show the typical fear or stress response to punishment cues or to seeing others in distress.
So they lack that internal stop signal.
Kind of, yeah. They lack the typical emotional response that makes most people hesitate to hurt others or break rules. It's like their fear system is dampened.
And the kids without LPE.
Those kids, particularly the childhood onset ones without LPE, often show the opposite pattern: hyper-reactive emotional responses. They tend to be over-aroused, quick to anger, especially when they feel provoked or threatened. Their aggression might be more reactive and hot-headed, whereas the LPE type is often more proactive and cold-blooded.
That difference in arousal under versus over seems critical for treatment, right?
Absolutely critical. It tells us we might need very different approaches depending on the underlying profile. But first, getting the diagnosis right involves gathering info from multiple people, parents, teachers, the child too, if possible. Context is everything.
And we have to remember the huge comorbidity, especially with ADHD,
Yeah.
like 60 to 80% overlap in clinical samples.
Right, and treating the ADHD, often with stimulant medication, can sometimes significantly reduce the ODD or even CD symptoms. It targets the underlying impulsivity and attention problems that fuel the defiance.
So what works best for ODD itself, especially when caught early?
For ODD, particularly in younger kids, say, before age 9, parent management training, PMT, is really the gold standard. It's heavily based on that coercion theory we talked about.
How does it work?
It directly teaches parents practical skills to break that cycle. Things like using positive reinforcement, effectively catching the child being good, giving clear, direct commands, and using consistent non-physical consequences like time out for misbehavior. It empowers parents to manage the behavior more effectively and build a more positive relationship.
Okay, that makes sense for younger kids. What about older kids, adolescents with full-blown conduct disorder? The problems seem much bigger then.
They are. For adolescents with CD, especially severe CD, the interventions need to be more comprehensive, more intensive, and often involve multiple systems in the child's life. The book highlights 2 evidence-based models.
Which are?
One is functional family therapy, FFT. This really focuses on the family system, improving communication, negotiation skills, and finding ways to motivate the adolescent and the family towards positive change.
Okay. And the second?
The other is multisystemic therapy, MST. This is a very intensive approach that works with the adolescent in all the environments where problems occur: home, school, peer group, community. It identifies the specific drivers of the conduct problems in each system and develops interventions to address them simultaneously. It's about changing the whole ecology around the youth.
Both sound pretty involved. But what about that LPE subgroup? Do these therapies work as well for them? They sound like the toughest cases.
They generally are tougher, yes. Research shows that youth with CD and LPE often start treatment with more severe problems and, unfortunately, tend to have poorer outcomes even with these effective therapies like PMT, FFT, or MST.
So what's the direction for helping them?
The field is actively working on adapting these treatments. The focus is on strategies tailored to their specific deficits, things like enhancing parental warmth and positive involvement, using reward-based systems much more heavily than punishment, since they don't respond well to punishment cues, and even directly teaching emotion recognition skills to try and build empathy. It's an ongoing challenge.
This has been incredibly insightful. So to recap, we've seen ODD and CD defined by specific clusters of behavior and emotion, needing careful diagnosis considering development. We understand the transactional nature, especially through coercion theory, and that CD isn't monolithic. The age of onset, and particularly the limited prosocial emotion specifier, are vital for understanding the pathways and prognosis.
Exactly. And perhaps the most provocative thought from this is how the research is pointing towards these distinct pathways. The LPE group with its characteristic underarousal, the non-LPE group often showing hyperarousal, and the adolescent onset group may be driven more by social factors. As psychiatry gets better at identifying these specific mechanisms, these different whys behind the behavior, especially the biological differences, well, it opens the door to developing truly tailored mechanism-based treatments. The future might be less about just managing the behavior, the what, and more about targeting the specific underlying reasons, the why, for each pathway.
That's a really hopeful note to end on, moving towards more precise and effective help. Thank you for joining us on this deep dive into ODD and CD. We hope this exploration helps you navigate this complex area of child and adolescent psychiatry.